Is that
Yes.
all right? Yeah, great. Thank you, Matt. It's a pleasure to be here. I'm going to focus on the investigation of traumatic brain injury, talking particularly about imaging, but also ending with blood tests, which are not yet mainstreamly available, but I think are coming rapidly. So we'll end with that. So hopefully the slides will go forward. Oh, connection lost. That's not a good start. Maybe we can move it forward for me. That's great. So in terms of the kind of more severe injuries, we're interested in picking up a range of different, quite complicated effects to the head. So going from the outside, obviously scalp hematomas will be obvious, but fractures, we want to pick up bleeding around the brain, so extradural, subdural hematomas, bleeding within the brain, and then life-threatening problems acutely, such as brain swelling and compression of different brain structures. Now, the mainstay for doing that is neuroimaging, and a lot of this can be picked up acutely by CT. And what I'll do initially is just run through very quickly the things that CT and MRI can do well. Just go forward one for me. Thanks. So CT is what people would get acutely in A&E in our major trauma centres. It's very good for identifying certain things, particularly blood and fractures, and guides most of very acute management. It's much less good at imaging brain structure. And as Richard pointed out, it's very often negative in situations, even when we think that there's been a significant brain injury. And obviously it does involve some radiation, so there are concerns about repeated exposure. Just forward one, please. Now, MRI scanning is not so much used in the hyperacute phase, but tells us much more about brain structure and pathology within the brain. It's very flexible at looking at different aspects of brain structure and function. There are some limitations of using, particularly in a very kind of acute trauma setting, because of MR safety. And just forward one. And finally, just thinking about imaging, there's a range of molecular imaging that I'm not going to talk about, but it's kind of interesting and important perhaps going forward, because it gives us measures of specific proteins and abnormalities in the brain, for example, that might be relevant for neurodegeneration or the development of dementia. Just go forward one. So firstly, just about what CT scan's good for. Just go forward one, please. So it's very good for picking up fractures. This is an example you can see there on the right of quite a nasty skull fracture that would be quite obvious on CT imaging. Go forward one. And this is an extradural hematoma that you'll be familiar with, which will show up very nicely on a CT scan. This is the kind of thing that our major trauma units are sort of set up to identify quickly. This is exactly what the neurosurgeons want to treat very quickly in theatre. So this patient is at severe risk of death and needs to be taken to theatre rapidly. Just forward one more. So underneath the dura, if blood collects, it's called a subdural hematoma. This is often seen with head injuries, but can be kind of more chronic, can be often seen increasingly in elderly people who are often on anticoagulants. So it's a kind of increasing issue for people on various types of platelet therapy or anticoagulant medication. Go forward one. So we've got various other types of bleeding, for example, around the brain, subarachnoid hemorrhage, you can see here. Go forward one. Here you can see some intraventricular hemorrhage just at the base of the ventricles, and forward one. And finally, a kind of large hemorrhagic contusion within the brain. And all of these things are, would be causing significant symptoms, but are very visible on CT imaging. Go forward one. And we can see the thing that we're concerned about often acutely and in severe injuries is whether there's any buildup of pressure. Here we see a kind of significant amount of what's called midline shift. So the buildup of a subdural hematoma which is pushing the brain over to one side. And this patient would really need an operation. Go forward one. Here we see kind of pressure downwards through into the brainstem. Again, likely to cause major problems if not treated rapidly. Forward one. And here there's a hemorrhage within the posterior fossa. So this is an area where there's lots of very vital structures, and so pressure around the brainstem can cause rapid death and needs very quick treatment. And forward one. And there doesn't have to be significant blood in the brain to cause problems. Often you get a kind of a diffuse swelling of the brain, which can also cause major issues. Forward one. And this is an example of a patient who came into St Mary's A&E, and it's just to illustrate the kind of evolution of problems. So the initial day 1 CT scan didn't show too much, but go forward. But by day 3, there were very significant contusions in the frontal lobe. Here you can see those right at the front with the kind of white bits, a hemorrhage within a orbitofrontal contusion. And then go forward. This patient was on the intensive care unit, was not responding to medical treatment, and ended up having this kind of life-saving operation, a decompressive craniectomy, where the surgeons took the whole of the front of the skull off. The patient actually did quite well in the end, despite what looks to be a sort of catastrophic CT imaging at this stage. Go forward one. So where does kind of magnetic resonance imaging fit in? Well, I think it's particularly good for those things that don't show up well on the CT imaging. And as we heard, that's often the case in mild or kind of mild complicated TBI. Go forward one. And I thought I'd just illustrate this. So this is a kind of map of where we see contusions. But if we go forward one, there's a whole kind of range of diffuse injuries, and particularly diffuse axonal injury, which may not be something you're so familiar with. But that's the idea that often head injuries can damage the wiring, the connections within the brain. So the axons connect different parts of the brain to each other, and they can be particularly susceptible to the forces exerted at the time of an injury. And the important point is that it doesn't necessarily show up well on a CT scan or even a standard MRI scan, but can be very important for long-term outcomes after TBI, and are often associated with very small hemorrhages. So what's called diffuse vascular injury, which is not the big kind of hemorrhages I've shown you so far, but much less easy to pick up. Go forward one. Now, at 12 months, he'd actually had a very difficult time, which is not unusual for these kind of patients. So he was apathetic. He had a lot of motivational problems. He was actually at university and had really struggled to get back to studies. He had attention and concentration issues. He was part of a study that we were running, and so we had quite detailed investigations over time on him. And it's a little bit complicated. These are the kind of cognitive tests. But if you look at the kind of right-hand column, that's his percentile score on cognitive function. So at 12 months, he was down in the kind of 20th percentile, which for somebody at university was really worrying. Just go forward. And he'd required lots of input from neuropsychology, from occupational therapy, from vocational therapy. He was actually being started on methylphenidate because of the cognitive and attentional difficulties. And so this is a kind of example of somebody who, in the first few hours after their injury, looked to be not severely injured. The CT scan was normal. He could well have been discharged without any kind of follow-up at all, but he had a significant injury, certainly in terms of the problems he developed over a number of months, and in fact years. I've seen him now a number of years later, and he's still struggling with many of these issues many years later. So what's going on? What's the explanation for why he should develop so many problems? If you go forward. So this was his MRI imaging. So actually the basic MRI scans don't really help that much. So this is a T1 volumetric scan and a T2 flare scan. These are kind of the standard MRI imaging we get, and they were completely normal in his case. However, we have some new types of imaging, which is more sensitive for subtle but important effects of injury. And particularly if we want to look for what's called diffuse vascular injury, we can look by using a technique called susceptibility weighted imaging, or SWI. And that shows us essentially bleeding around blood vessels within the brain. If you go forward one, we can just blow up his SWI. And we can see that this is not entirely normal. So the black bits, you can see there are actually a very detailed imaging representation of his veins, the veins in the brain. And if you look on the kind of left, I can't use the pointer unfortunately, but the left side of the brain, there are these little black dots that are quite visible there. And essentially they're what's called microbleeds. So they're kind of bleeds around the blood vessels that are not big enough to show up on a standard MRI or on a CT scan, but that we can see very easily on SWI. So this is a kind of method that's available very easily and forms part of most of the kind of trauma assessments, and can be useful in identifying these kind of more severe cases of brain injury. Just go forward. And this is just a kind of a paper that describes exactly what they're due to. Just go forward a couple if you click through. The important thing is the last one here. So actually what the imaging is picking up is these tiny bits of bleeding around the blood vessels. And actually the kind of hemosiderin from the blood gets gobbled up by macrophages or microglia. And those cells sit there for years. And so it never really changes. So we can kind of pick up the long-term effects of these microbleeds many years after an injury. So it can be a very useful marker of a significant injury. Go forward one. But I think the key pathology that's often missed in traumatic brain injury is diffuse axonal injury. And this is damage to the wiring. And we can see an example here back from the 1950s when it was first described in London by Strick, who did a whole series of very beautiful kind of studies of post-mortem cases. This was a 28-year-old who died after being hit by a truck. And the black stain there is the white matter connections within the brain. And what you can see in the kind of the middle of that is this kind of paler area, which is actually a kind of degeneration of the white matter tracts in this patient. So although there was no contusions or damage within the outside of the brain, the actual wiring of the brain was very severely affected, and that's why this patient was so severely injured. It was nothing to do with cortical damage or bruising or anything. It was actually just a disconnection of the white matter tracts. And go forward. And so we think that this is a really, really important type of injury that's produced because of the biomechanical forces that are exerted on the brain at the time of the impact. And there's a little cartoon showing a kind of blow up of the axons. And the axonal structure is very vulnerable to these kind of forces. Neil Graham will talk about this in the context of neurodegeneration a little bit later. But essentially, the wiring can either get stretched and the internal kind of biological formation of the axons gets damaged by the trauma, and that can lead to long-term disruption in the functioning of those axons, even if they're not completely severed. Go forward. So we have some sort of a very nice way to look at this using MRI imaging. If you just click on that, we can use something called diffusion tensor imaging, which allows us to map out the structure of the white matter wiring in great detail. And the colors here represent the directions of the white matter tract. This is an individual subject's scans. And what we can kind of do is zoom in to particular areas and ask questions about how intact those fibers are. So we can see in red as it comes around there, that's the corpus callosum, which I'll talk a little bit about, which crosses the midline. And that's an area that's particularly susceptible to the effects of injury because the two hemispheres can kind of show a lot of force across the midline. So you get a lot of shearing force across the midline, which produces major damage at that area. If you go forward, what? So on the bottom left, again, is a kind of nice image of an individual's white matter tract structure. That what we want to do is kind of go in and probe the structure of that, and we can do that for particular areas. So I've shown for the corpus callosum, so this is the midline structure here, color coded for different parts of the corpus callosum, the splenium at the back, the body of the corpus callosum, and the genu at the front. And essentially we can kind of go in and do like a virtual biopsy almost. We can kind of say, well, what's the structure of that little bit of the brain, and has it been affected by the injury? And what we can see plotted on the top right is the structure of the splenium of the corpus callosum using this particular technique. And the red areas are all the clusters of lots of controls. So everybody has a very similar structure of that region, but the blue areas are the readout from patients with traumatic brain injury. So we see that this is very commonly affected. If you go forward one, and in our studies, certainly for moderate severe injuries, we see about 50% of the patients have diffusion imaging evidence of axonal injury. So this is not an uncommon finding, and we see that that predicts clinical outcomes, particularly cognitive function, and also neurodegeneration, which Neil Graham may talk about later. So we've got a very potentially a very powerful way, I think, of looking at white matter structure within the brain that gives us a kind of readout of whether there's been injury, which we've often been missing, I think, in the past. Just go forward one. So I think in the last 2 or 3 minutes, I just wanted to talk about blood testing for brain injury. So this is a sort of new frontier, I think, and I think it's something that you're going to hear much more about over the coming years. Essentially, it's been very difficult to do blood tests for neurological conditions because of the blood-brain barrier. So what happens is that the abnormal proteins that build up in the brain are blocked from coming into the blood in high quantities because of the blood-brain barrier. So the technology has kind of evolved to the point now where we have various technological platforms that allow us to measure the concentration of abnormal proteins in really, really tiny concentrations very accurately. If you go forward, and what that allows us to do is measure a whole series of proteins that relate to a whole range of different neurological conditions. And we're focusing on here are the ones that are relevant to traumatic brain injury. We've done quite a lot of work on one called neurofilament light, and that's a protein that's found within axons. Normally it's contained within the axons, but it's released by damaged axons, and it finds its way in the blood, and that can be measured in the blood, so we can get a good readout of whether there's axonal damage. You know, the neurons are not sitting in isolation. They're kind of surrounded by glial cells like astrocytes and microglial cells. Now, astrocytes are often affected by traumatic brain injury, and we have a very good readout of that, something called GFAP, which we can measure in the blood, is another very sensitive marker. We've got measures of tau, which is a protein that's often affected by TBI and also is a marker of neurodegeneration. We've got, again, amyloid markers, which are affected early on, and other measures of neuronal damage. And just go forward one. And I just wanted to mention the phosphorylated taus are particularly interesting, and it's an area that's in the news a lot at the moment, because essentially one particular phosphotau, so phosphotau 217, looks as though it's a really great measure, a screening test for Alzheimer's disease. And there are some major studies going on that are allowing us to test really how good that is and how close it is to clinical practice. I think this will come in the next 2 or 3 years. Just go forward one more. And this is just to say, you know, how prominent the signal is for neurofilament light. So what I'm showing you here on the left is the readout for healthy controls. The y-axis here is actually in log scale. So most people are around 10. But what we see in the first 10 days and then 10 days to 6 weeks, which are the next 3 columns there, the blue dots are patients who've had moderate severe TBI, and we can see a dramatic increase in neurofilament light in the blood. And actually the red dot, if you can see that there, is our patient that I told you about. So this is somebody who didn't show anything on the CT scan. Nobody was particularly worried about him, but by 10 days, 6 weeks, he had an NFL of 10 times what you would expect it to be. So I think this is a test that in this particular case would have been very informative and really would have confirmed the fact that this gentleman had a significant injury. So go forward one. So just one last slide in conclusion. So I've told you about what CT scanning is good for. It's good for identifying blood and fracture in the brain. MRI is much more sensitive to damage within the brain. And we have a whole range of different types of MRI that can be helpful. So susceptibility weighted imaging and DTI are both informative about subtle injury within the brain. And then I think blood biomarkers are coming in a whole range of areas in neurology, but I think they're going to be very useful in traumatic brain injury in coming years, and will change the way that we're assessing mild TBI and as well as more severe injuries. And I'll stop there.